Well, welcome back. This is Chapter 3, Part 2, and I know you're sitting on the edge of your seats to be able to hear more about the guiding principle of healthcare ethics, which is exactly what we're going to be talking about. So there's 8 areas that we're going to be talking about. Preserve life, do good, respect autonomy, uphold justice, be honest, be discreet, keep promises, and do no harm. So for the first one, preserve life. We realize that life is precious. We are always going to try to preserve life if that is what the patient wants. Even if it's not what the patient wants, sometimes we still feel an obligation to do that. There is not any type of definition of what life is. That is some of the issue that we're facing with abortion. Does life begin when the embryo is conceived? Is it at 15 weeks? Is it at 20 weeks? Is it at 30 weeks? Or is it all the way up until delivery? And when we talk about death with dignity, when is it all right to be able to allow somebody to choose a time for them to die? When is life no good for that patient at that point? And this is really, sorry, I have a clock in my dining room, which is now my office, that plays music every hour. So you just got to hear the beginning of Bridge Over Troubled Water. So again, when is it okay for people to say, enough is enough, I'm ready to go? This is huge. It goes against people's religion. It goes against those personal beliefs. And so we have to think about these things when we're talking about ethics and the preservation of life. Again, when is it okay to put somebody on a ventilator if we know that they don't have, they're not going to have a quality life? That's a good question. Who makes that decision? Do they have a healthcare proxy? Do they have a decision made? Have they let their family know what they would like? Those are things that that people need to be talking about with their family. Euthanasia, again, it's really called death with dignity. We euthanize animals, but it is only legal in 8 states. And so those 8 states have very strict laws and guidelines that anybody has to follow if they want to do the Death with Dignity Act. So you just can't go to Washington, D.C. one day and say, listen, I want to I want to die tomorrow. They're not going to give you the medication, and then you're not going to be able to take it. There's a process that you have to go through. So, again, that's something that we need to think about. So, it is illegal in most states to withdraw artificial means of supporting life. Is that true or false? It's false. It's not illegal to withdraw life support under certain conditions, but again, that's with families' approval. That means that ethics committee that we talked about looked at all the scans, looked at the brain waves, looked at everything to say there is no hope for that patient. We are going to remove them from the ventilator. So, some of the dilemmas that we face when we talk about preservation of life is, again, we've already talked about death with dignity, but organ transplant. Organ transplant is huge. We now can put this on our license and it will hold up that if we want our organs donated to someone. My belief has always been take what you want because I don't need it anymore. But that is very much not the case with certain religions who believe in reincarnation. They don't want anything taken away from that body because they believe that they come back to life in another form and they need every single part of their body. We don't have to agree with their thought, but we do have to respect it. And this is a big one right now that we are living with the coronavirus. rationing care and resources. So when you look at this coronavirus and how it's affecting the world over, Italy had to make some very, very tough decisions. They had to put into law that if you were 80 years old or older with a coronavirus and needed put on a ventilator, that they had to refuse those patients. They had to tell the family members, I'm sorry, but your parent is over 80 years old and they cannot be put on a ventilator. And that's because when we have emergency situations like these pandemics, the rules change very quickly for healthcare. Normally we try to save everybody, but in an emergency situation, we have to look at what's going to be best for the country or the area as we grow back and go back from the effects of this horrible pandemic. So an 80-year-old doesn't have a lot to offer. I'm getting close, so I may have a little bit of a disagreement with that. But an 80-year-old person isn't going to be able to have children. They're not going to be able to build companies and bring the technology that's needed back into the area. It's the young people. It's the people who are still very viable and able to give back to the community and build the community back up. And so it's a very different way of looking at things, but unfortunately it is something that we have to do in certain times. So, which of the following patients would most likely receive a liver that becomes available from a donor? Would it be A, a patient who has never abused alcohol, B, a patient who will likely die within weeks without a transplant, and C, a patient who can best afford the surgery? So take a minute to think about that. And the answer should be B, although there's many, many factors that are taken into account on who's going to get that organ. Medical urgency is the most common consideration. And so the person that's in the most need is the one who's going to get it. The next area of healthcare ethics is do good. Again, hopefully our basic duty as a healthcare provider is to promote the welfare of others and work for the best interest of the patients, right? That's what we do. So that was quick and dirty. Do you know how many times I say so? It's driving me nuts. Anyway, I know you'll laugh now because, yes, it's Lisa. She's a squirrel at her house, just like she is in class. The third area is respect autonomy. This is self-determination, and this is a law. The patient has the right to determine what they're going to do. They're allowed to make their own decisions. So they can refuse something, they can choose the type of therapy they want, but the decision is made by the patient. We don't have to agree with it. If we go back to that person not getting blood, knowing that simple act could save their life, but it's against their religion, they have the right to refuse that, and we have to honor that. We also have to talk a little bit under this category about permission. And when we talk about permission, it's consent. And in your textbook on page 73, there is a explanation of the different types of consent that's out there. So informed consent is going to be where the doctor or the person performing the procedure is going to tell them what they're doing. Any information about alternatives, well, if you in addition or in place of that, you could do this. The risk, benefits, and uncertainties of the procedure, making sure the patient understands, and they have to talk about, the risks and percentage of death and those type of things. And it sounds horrible, but we have to give the patient every piece of information because they're going to be signing on the paper that they are giving consent for that procedure. So in order to do that, they have to have all the facts. That's informed consent. So if you're doing something invasive like surgery, or maybe a biopsy of some kind, you're going to be signing informed consent because they're doing something invasive to the body. There's other types of informed consent as well. One is implied consent, and implied consent is when you show up for an appointment. You're giving them, you're giving permission for them to treat you because you showed up. It's when you open your mouth at the dentist office when he says you've got a filling and I need to fill it. So we're implying that by opening our mouth or by showing up, we are giving consent for that procedure. Express consent is a little bit more formal. And again, it can be either in orally or written, and that's where they're giving permission to a provider to receive that treatment. Again, this is when we were talking about the informed consent. They are going to be told about all of those things that can happen, and they may, for informed consent, they're going to be signing the paper. Express consent can be oral, but if we're doing a major invasive process, it will be a written place, or a written format. One of the things with consent is that what the patient's doing is saying that the doctor talked to them about all of those things. Informed consent requires a witness. As a student, you cannot sign as a witness legally. Once you're out of school and working as whatever, you can be a legal witness. And what that means is when you sign that you legally are the witness, is that it is the patient's signature and they signed it on the day that is on the paper. We are not signing that they understood, that all of those things were said. That is not at all what we're signing for. The only thing we're doing is saying, this is the patient's signature and this is the date they signed it. The patient signs that they understand everything else. When we look at who can give consent, mentally competent adults can give consent. Means that you're not under the influence of any drugs or alcohol. And emancipated minors are able to give consent as well. When we look at an emancipated minor, this is someone who is under the age of 18 years old. They are financially independent. They're married. They're in the military, or have been emancipated by the court. So if somebody gets married at the age of 16, they are considered an emancipated minor and can sign for themselves. So we talked a little bit about this informed consent, procedure explained with the consequences, implied is by our actions, express is given in writing. You can do it in oral, but writing is a much better way. Okay, so when we also look at consent, we have to talk about patients and how we work with them. So battery, assault and battery, you hear a lot, that they were charged with assault and battery. Assault is threatening to touch or treat a patient without permission. So let's say you go to draw blood on somebody and they go, no, you're not drawing my blood. And you say to them, if you don't put your arm down, I'm going to hold it down and stick you. That's assault. When you touch the patient, that's when the battery happens. So we cannot make patients give blood. We can't make them take medication. They have the right to refuse. So be very careful with that. Don't say, I'm going to hold you down. Don't hold them down. All of those things are illegal acts and you can be charged. Again, false imprisonment then is holding mentally competent patients against their will. So let's say a patient's in the hospital and they've had enough and they want to go home. And the doctor said, I don't think that's a very good idea. And the patient said, I don't care what you think, I'm going to go. There's no way we can hold that patient in the hospital if that is not what they want to do. If we do that, we can be charged with false imprisonment. What they're going to be asked to do, though, is sign a paper. It's called AMA, Against Medical Advice, that they are leaving against the medical advice of their physician. So, if a patient, there goes my so, if a patient schedules a root canal and shows up at the appointed time for the procedure, what kind of consent is this? Express consent, implied consent, or informed consent? Hopefully you said implied, because their actions of showing up to the appointment and again then opening their mouth during the appointment would make it implied. We also have issues of advance directives, and these are written instructions about what the patient wants regarding their health care. So the first thing that we're going to look at is a living will. These are health care instructions. This is they're telling someone what they want done. If I'm, not able to speak for myself, this is what I would like you to do. I don't want to be put on a ventilator. I don't want a feeding tube. I don't want you to do CPR. There's a number of things that they can list out what they will or will not do. Okay. A living will is required or regulated by state laws. And the one issue with a living will is that while they have to be regulated by law, if a family member comes in and they don't have the living will and the family member says, no, that's not what I want, they will do what the next of kin are going to say. They shouldn't. They should honor the living will, but I have seen it happen where they weren't aware that there was a document, and then it came to light after the patient, after the wishes of the family were taken. So the patient, in the instance I'm thinking, the patient said, I had cancer, I do not want to be resuscitated, and they did not show they didn't have the living will that they had written out. The family said, we want everything done. They put the patient on a ventilator, and then all of a sudden the living will came to light. And was a problem because the patient specifically said they didn't want that done, but the family members kind of overrode that because the document wasn't there for us to see. So it can get sticky sometimes. The other thing that we have out there is called a durable power of attorney. Now, this is specifically for health. Power of attorney in general is finances and everything. The durable health power, or I've heard it called durable power of attorney for health, or durable health power of attorney, all kinds of different ways depending on the state that you're in. What it does is it identifies a specific person, and they have the authority to make the decision on what's going to happen to you if and when you are unable to speak for yourself. This is really important because if you have specific beliefs, I do. My husband knows exactly what I want, and we were making an appointment to our attorney to get our wills redone because it's been years since we've had them. And he said, please think about your healthcare power of attorney because you need to make sure it's a person that will make the decision that you want. And it was funny because my children both said, don't let Dad do it because Dad would never let you go. And I looked at my husband and I said, they may be right. But make sure it's the person that you believe will follow your wishes. That's going to be incredibly important. Even if it's not a family member, If there is a legal power of attorney for health, they are the decision makers, not the family. In 1991, the Patient Self-Determination Act was enacted, and it says that healthcare facilities have to provide adult patients with information about advance directives. Without those instructions, care of incompetent patients are difficult. So every time you go in to have something done at the hospital or even an outpatient, you're initialing all over the place. One of those initials is, do you want to have a living will done or advance directive? And if so, if you say yes, then they ask you if you want to talk to somebody. So you're signing, no, I don't want one right now, in some cases. So you need to be careful what you're signing or initialing without knowing. A lot of people will do that, and it will come to bite you in behind. If you're signing a legal document, make sure you know what you're initialing or you're signing. One of the issues with this Patient Self-Determination Act, they get to make decisions about their care, but the problem is sometimes it's done a little too late. So let's say we have a patient with Alzheimer's, and they're wanting to decide, I don't want anything done, and their family member steps in and says they are not in sound mind. The doctor said, well, I agree. So that patient no longer has the ability to make that determination. So this needs to be done at a time where people are of sound mind, so it will be carried out. So true or false, a patient admitted to the hospital is legally required to sign a living will. Nope. They are not legally required to prepare advance directives. However, the healthcare facilities have to tell the patients that they have the right to do that. And there are people at the facility that can help them with that process. The fourth thing is upholding justice. Justice really refers to being fair. So this is where we treat everybody the same. And in reality, we know that that's not true. You know that somebody who's very rich gets VIP treatment. And people who live in very poor urban areas do not have the same access to healthcare resources that people in a very affluent section of town have. Our healthcare services are ranked, and you can go in and look to see where the highest ranked services are, and usually that is not always in the middle of an urban area that is not in a well-to-do neighborhood. So while we say we're going to be fair, in essence, and this is a Lisa-ism, I do not believe we are fair. Reporting abuse, we have to protect other people from harm. And that is when we have to be able to report abuse. There is a Federal Child Abuse Prevention and Treatment Act, and that is telling us when we can, or when we have to be able to report child abuse and or elder abuse and domestic violence. Every state is going to be different, and this is really important because Maryland has very interesting reporting. We do report elder abuse, we do report child abuse, but domestic abuse is an interesting prospect. On your worksheet, I actually gave you 2 links for you to do a little bit of research about that in Maryland. We do have to report abuse. We are not going to be the reporter. We are going to report to our supervisor. The supervisor will probably take it to a physician, and then it will be reported at that level. We are not the person reporting because we're in a hierarchy in an office or in a facility. Patient confidentiality does not matter at this point because we are trying to save either an elder or a child from abuse. You definitely need to look and recognize the signs of abuse. And it's actually really sad when you see this. We see a lot of elder abuse. These are people who are collecting the Social Security check, and they are not taking care of that family member or that older person. And so on page 76, it gives you some signs of abuse for children, which is going to be bruises, welts, burns, lacerations or abrasions, skeletal injuries, head injuries, repeated injuries at a higher rate than normal for a child, different explanations for the cause of an injury, and usually compliant, fearful, or aggressive behavior of the child. Now, this is a tough call. My son Brian was a klutz, and he was in every sport, so he had bruises and bumps and, cuts everywhere. And I was always worried because I thought somebody's going to think I'm abusing this kid, and I wasn't. So we have to look at the situation, but if you have any thoughts that may be the case, you need to err on the side of the child's safety or the elder's safety. Okay? Under elder abuse, it also gives you some information about that. It can be the lack of proper care. They can come in, not wash, not bathe, bed sores. They can have physical or abuse. Sometimes they get hit. Mental and emotional abuse, we see a lot of that. Sometimes sexual abuse, and sometimes they're abandoned. So very sad in both cases to see these things. I want to just go to domestic abuse. There are states that have mandatory reporting for healthcare providers about domestic abuse. There are some things when we start talking about rape and we start talking about a firearm injury, stabbing, those kind of things, those are indeed reportable. But again, make sure you're looking at the links I sent you because it goes by county. It's very interesting. But domestic abuse in each state is a different type of reporting. So you need to be aware. It goes back to understanding the state laws. You need to understand what the laws are in your state for the domestic violence that's out there. When we look at laws, again, that are protecting us as well as our patients, the first one is OSHA. It's the Occupational Safety and Health Act. It actually requires employers to be responsible for our safety. It's only for employees, and they are required to provide us with personal protective equipment, safe workplace, those type of things. So if you are drawing blood and OSHA walks in and they see you rip your finger out of your glove because you can't feel a vein, that's not a good thing. They're going to fine you. You need to have gloves on. So if you can't feel a vein with your gloves on, you need to find somebody that can. Those can be up to a $10,000 fine, and that's a lot of money. If that agency gets fined $10,000, you're probably not going to have a job the next day. So please make sure you're using the personal protective equipment that is provided for you by your employer. We also have the Controlled Substance Act. This is supposed to help with the abuse of addictive drugs. There's a number of different categories. We have schedules 1 through 5 in this Controlled Substance Act. Schedule 1 being the most addictive and not having a health benefit. Those are like cocaine, heroin, marijuana is in that category. Schedule 2s are when we start to see a medical use. And so that's going to be things like oxycodone, those type of things. And then as we get down to the 3s and the 4s and the 5s, it's less addictive, physically addictive and mentally addictive for each category. There are specific guidelines for prescribing and handling these drugs. So again, if you are working with scheduled drugs, you need to know the regulations for each one of those schedules. Very, very different. Some can have refills, others cannot. Schedule 2 drugs cannot have a refill, and it has to be handwritten. Schedule 3 and 4, you can have up to 5 refills, so it's good for 6 months. And then Schedule 5, it does not matter. So it's very important to know that there's a difference in each one of the schedule, in refills, in the type of forms you have to fill out, and everything. It's very important that you know that. Being honest, we definitely need to be honest. We have to look at things like getting your patient's trust. If you do something wrong, let somebody know. Don't be afraid to report an incident. We have something called an incident report. If we make a mistake, when we're owning it, that's how we learn. But please make sure you're filling out the incident report, because if you're hurt on the job or something happens, if it's not filled out, usually within 24 to 72 hours, depending on policy of the agency, they are not going to cover you for any of the care. So it's really, really important. The dilemma with this is, how much do you tell patients about their condition? And that is not for us to decide. Again, that is for the physician and the patients to decide. Sometimes we don't agree with it. A patient may have AIDS and they say, I don't want you to tell my wife, or has HIV, and we have to honor those wishes. Okay? Fraud is a huge piece with this, and we know this usually happens with coding and billing. Upcharging or upcoding, where we're charging, coding that we're doing something and we haven't done it. We have a higher level visit than we really actually did. You need to be incredibly careful with this, because you do not want to get caught. The federal government will find you, and the physician's going to take the most heat, but you really just don't want to be involved in a situation like that. Be discreet. Again, confidentiality. It's all about the confidentiality. We cannot release information without their written consent. We know that. Every time I go to the doctor, they have me review that. Is it still okay that we contact your husband with this information? And, they're constantly updating that. We absolutely cannot release information without the patient's permission. HIPAA, we know. God, zippa your lippa for HIPAA. You all know this. You'll know it by heart by the time you graduate. It is Patient Privacy Act, and it's Health Insurance Portability and Accountability Act. It was written in 1996 and was updated by the HITECH as well. We have to follow facility policies about maintaining confidentiality. So, individual healthcare facilities must develop policies for protecting patient confidentiality. Is that true or is it false? It's true. Every office, every agency has to follow the federal guidelines, but they have to develop policies and procedures to maintain patient confidentiality. All right, that is the end of Chapter 3, Part 2. Chapter 3, Part 3 is just waiting for you. See ya. Bye.